Good morning, everyone. My name is Dr. Sri Saujanya Patibandla, and I am the chair of the IFM Research Committee. I will be your moderator today and for the top 4 research abstracts. This plenary is going to highlight the best of the best. We have received a lot of research articles over the last 1 year. And these are all the groundbreaking researchers, and it has been a tough time for all the reviewers to select and give you the best of the best today. And these abstracts are going to be presented here are the cutting edge researchers that has been in the field of emergency medicine. The presenters you will hear from you today are not only pushing the boundaries of the emergency medicine research, but are going to be bringing them into the practice or giving us the more evidence that how we are going to practice today. With this, whether you are a clinician or researcher or educator, these are going to change the way we are going to practice, and these are going to give us a new enlightened way of how we are going to practice emergency medicine. And with this, today our first speaker is going to be Dr. Ian Steele, a distinguished professor of emergency medicine and epidemiology and public health at the University of Ottawa. And he's a senior scientist in the Ottawa Hospital Research Institute. His research has focused on clinical decision rules and risk scales, as well as clinical trials in cardiac arrest and acute atrial fibrillation. Dr. Steele has had more than 490 peer-reviewed publications and directs the International Ottawa EM Research Fellowship. He also is editor-in-chief of the Canadian Journal of Emergency Medicine. Please welcome Dr. Steele to present Vernakalant versus procainamide for rapid cardioversion of patients with acute atrial fibrillation, a pragmatic randomized trial. Welcome you.
Good morning, everybody. I have to start by saying that this has been a fabulous conference, and I really want to thank and congratulate the ISOM organizing committee and IFM and CAPE. You have done an amazing job, so thank you for that. It's my pleasure and honor to have this opportunity to tell you about our RAF4 randomized trial where we compare Vernakalant to procainamide for the rapid cardioversion of patients with acute atrial fibrillation. I want to thank and acknowledge my many collaborators on this study, it was conducted by the Department of Emergency Medicine at the University of Ottawa in collaboration with 10 other sites. It was funded by the Canadian Institutes of Health Research and the ACT Consortium, and we have no conflicts to declare. As you all know, acute atrial fibrillation is one of the most common presentations of arrhythmia that we see in the emergency department. In Canada, our ED physicians typically will attempt to cardiovert most of these patients either with IV procainamide or electrically. Procainamide is a type 1A antiarrhythmic agent. It's older, modestly effective. Vernakalant acts preferentially in the atria. It's a newer drug and is believed to be more effective, but the two drugs have never been compared to each other. So the objective of the RAF4 trial was to conduct the first randomized comparison of the effectiveness and safety of IV Vernakalant to IV procainamide for the ED management of acute atrial fibrillation. This was a comparative effectiveness patient randomized trial with concealed 1-to-1 allocation. We did an open label comparison in 12 emergency departments of tertiary care Canadian hospitals and included acute atrial fibrillation patients for whom cardioversion was considered to be safe. And the interventions were the IV infusion of either Vernakalant or procainamide. Primary outcome was conversion to sinus rhythm within 30 minutes of the completion of the infusion. Secondary outcomes included the time taken to convert to sinus rhythm as well as the number of patients who subsequently required electrical cardioversion. This gives you some detail of the drug infusions. Vernakalant is given over 10 minutes and repeated one time if it doesn't work. Procainamide, we give more slowly in 500 mils of saline to avoid hypotension. All patients, if they failed to convert with the drug, were offered electrical cardioversion. The data analysis, and I want to give a shout out to our superstar biostatistician, Monica Talliard, was on an intention to treat basis. We excluded patients who subsequently were found not to be in atrial fibrillation, and we conducted multiple logistic regression analysis controlling for stratification variables like age, first or repeat episode, site, some prognostic variables including sex, time from onset, past medical history of heart failure. And the effect was expressed as adjusted absolute difference and odds ratios. We also did a secondary per protocol analysis that excluded patients who never received the drug medication. This shows the flow of patients. We randomized 354 patients, and they were assigned as you see there. Turned out that 4 patients were not in atrial fibrillation. They subsequently were shown to be in SVT or atrial flutter, so they were excluded from the ITT analysis, which had 172 and 178 patients respectively. And after we excluded patients who never got the drug, we had 168 and 174 in the per protocol analysis. This shows the characteristics of the 350 patients in the primary analysis comparing procainamide and vernakalant, and you can see they're quite similar for age, sex, duration, and various other characteristics. This is the primary analysis result, comparing procainamide on the left to vernakalant on the right. In the primary outcome conversion to sinus rhythm, you can see 48.3% versus 62.4%. And the adjusted odds ratio favoring vernakalant was 1.9, and the absolute difference was 15%, both highly significant. Secondary outcomes included the time to conversion, 44 minutes for procainamide, 21 for vernakalant, meaning that the latter was 22 minutes faster, highly significant. The proportion of patients who required cardioversion was much less for vernakalant with an odds ratio of 0.6. And overall, the vast majority of patients were sent home in normal sinus rhythm with no particular difference between the two groups. And we look at the per protocol analysis, the same outcome measures, results are almost identical, no difference, so that's reassuring. We look at adverse outcomes, more common in the procainamide group, primarily due to hypotension requiring the interruption or discontinuation of the infusion. None of these adverse events in either group were considered serious. We followed our patients for 30 days. And you can see a small proportion of patients who had to come back to the emergency at least once. Overall, there were no strokes. There were no deaths that could be attributed to atrial fibrillation. And we were able to reach the vast majority of patients at 30 days, and most had returned to normal activities, and they had a normal sinus rhythm, heart rate around 70 in both groups. Looking at the subgroups, the one group that is significant, shows a significant p-value for interaction, would be the patients who are less than age 70 had a significantly better response to vernakalant. So that was quite striking. So what does all this mean? This was the first trial comparing procainamide to vernakalant for acute AF. We found that vernakalant was superior. A 15% higher conversion rate, 50% faster time, fewer patients require electrical cardioversion. Adverse events were similar in both groups. They were mild and brief. Hypotension was an issue in procainamide, and that's well known. Patient outcomes were excellent. Almost everybody was discharged home in sinus rhythm. There was no recurrence of AF at 30 days, and no stroke and no deaths attributed to AF within the 30-day period. Limitations, we enrolled the 4 patients who actually weren't in AF. They were excluded. 4 patients later withdrew from the protocol, but nevertheless, they were included in the ITT analysis. We have an economic analysis that's pending. Of interest, Vernakalant is available worldwide, but interestingly not in the United States. So in conclusion, this first head-to-head comparison, Vernakalant was superior with higher conversion rates, faster times to conversion, and we can say that Vernakalant's a safe and highly effective IV alternative for the rapid cardioversion and discharge of patients with acute atrial fibrillation. I want to thank our research team in Ottawa, as well as the staff at participating sites and our patient partner, Mr. Christian Chabot of Quebec City. And with that, thank you for your attention and be happy to answer any questions.
I'm just curious about the cost difference.
Over there, yeah. No, that's a really good question. And that's one reason the uptake has not been fabulous in Canada, because the drug's quite expensive, Vernakalant, and that's why we're doing an economic analysis. For example, in our hospital in Ottawa, the cardiologists are allowed to use it, but we are not. And there is a belief that there's this quite a, having a more effective and faster drug may give rise to some savings, but we will be publishing the result of the economic analysis. And Vernakalant's expensive. I have nothing to do with the company. I make no money talking about this.
Thank you.
Full disclosure.
I was wondering if you had looked at atrial fibrillation versus flutter, because flutter tends to be a little harder to convert, whether that was actually teased out or whether flutter wasn't even looked at in this.
No, good question, but flutter is excluded. So it's the drug, Vernakalant is not intended for flutter, so we had to leave them out, those guys.